Dr. Randy Martin with the Marcus Heart Valve Center at Piedmont, Atlanta, and I'm thrilled to be joined by Paul Grayburn. Paul is a dear friend and has made tremendous contributions to our knowledge about not only echo, but interventional echo and many other things. And Paul is currently the Director of Cardiology Research and as well as the Director of the Valve Clinic at the Baylor University Medical Center in Dallas. Paul, thanks for joining me.
Thank you, Randy.
So, Paul, you know, you've obviously we could talk about how do you quantitate ischemic MR, but that's a whole nother subject.
No one knows how to do that.
No, I know. But you've been at the forefront of transcatheter therapies for secondary MR, ischemic MR. Where do we stand with this? I mean, currently, where do we stand?
Well, in the U.S., the MitraClip is approved for degenerative MR, but not for these functional ischemics, although worldwide it's used very frequently for that. And I think, as you know, the MitraClip works well. Patients feel better, but it does leave residual MR. So there's been a lot of interest in other devices, things that mimic a surgical annuloplasty or even a surgical valve replacement that might get rid of MR completely.
Just for a second on the MitraClip, because I know if in an ischemic MR with a severely retracted and deformed medial, posterior leaflet and medial aspect of the valve, does the clip able to grasp that and reapproximate it okay in these patients?
Well, usually it does because we pre-select patients. Correct. If we feel that we can't grasp it, we don't even try.
Okay. So tell me, and we've had recent data out that continues to look like mitral valve replacement in ischemic MR may be better than repair for remodeling the ventricle and things like that. So where do you think that are the ring alone approach with transcatheter going to be adequate, or are we going to be looking eventually at a valve in that valve?
Well, it's maybe too early to tell for sure. I think that the ring approaches that use the coronary sinus are limited. As you know, there is a direct annuloplasty ring made by Valtech that looks very promising, and it appears, at least in preliminary data, not to have the recurrence rate that we saw in the CTS in trials with sewn-in rings by the surgeons.
So Paul, as far as transcatheter valve insertion, I mean, is it going to be a valve and a ring? Is it, whether there's going to be a combo, or are we going to there are multiple valves that are out there now that are getting ready to go through clinical trials, or is it going to be a pure valve, do you think?
I think it's likely to be a pure valve, although the real question is going to be the design of the valve and how you seat the valve in. There are all different types of approaches that have been thought of, and I think we're going to figure out which one works the best.
Do you think, the mitral, obviously the valve, the transcatheter valves are under a different pressure set and problems like that than the aortics. What about the anterior leaflet or shoving the residual leaflets up into the LV outflow tract and causing LV outflow tract obstruction? Has that been a problem in the early trials?
It has been. It's obviously a potential problem, and I think as we screen patients for this procedure, we have to be sure that we eliminate the patients that look like they're high risk for LVOT obstruction.
If you put your futuristic glasses on, where do you think we're going to be 5, 7, 10 years from now with transcatheter mitral valves for secondary MR?
It's hard to say. As you know, to date, there's no evidence that a surgical valve replacement improves survival in this disease.
Correct.
And that's going to be a big hurdle for transcatheter valves as well. What if we can design a perfect transcatheter valve that works like a charm, no LVOT obstruction, lasts 10 years, but doesn't make the patient better?
Well, it might improve their symptoms, but it doesn't improve their longevity, which is very different, isn't it, from the transcatheter aortic valves?
Well, that's true, but here's the other side of that, is that the MitraClip, although it doesn't get rid of MR, is super safe. And we already know, because there have been over 25,000 of them implanted, that it does relieve symptoms in functional MR. So I think that's another hurdle for the transcatheter valves, that they're going to be going up against a very safe transfemoral procedure where a lot of the patients go home the next day.
And so you brought up and we'll close with this, but I hadn't thought about this. So you're looking at, so say we come up with 2 or 3 valves that look good, you can put them in, but they don't improve survival. Now you've got one issue, and then you've got, of course, the issue of cost of all this. So you think that those might be 2 significant hurdles to get, even though you could design a valve well, to get it out into clinical practice?
I think so. I think you're going to have to make a valve that has the same transfemoral approach as MitraClip, so that it has the same safety profile. And if that can be done, and the cost is reasonable, and the patients feel better, I think there's a huge potential market for this, and our patients would benefit from it greatly.
Super. Well, listen, I appreciate it. I know I'm going to be watching what you're doing, because I know you're deeply involved in these things, and I think it's really cool. Thanks for joining me.
Thank you.
Thank you all for joining us too.